Welcome to Doctors on Call. I'm Jenna Miller. The heart is one of the most amazing and important organs in a person's body. The heart is made of muscle and powered by electrical impulses. It beats about 115,000 times and pumps approximately 2,000 gallons of blood each and every day. Every year, more than 800,000 Americans suffer from heart attacks, and someone has a stroke every 40 seconds. We'll learn more about cardiology and tips for having a healthy heart on tonight's Doctors on Call with our guests, Dr. Michael Hagle and Dr. Robert Fleming.
Presentation of Doctors on Call on Smoky Hills PBS is made possible in part by an underwriting grant from At Blue Cross Blue Shield of Kansas. We're committed to being a healthcare partner you can turn to. That's why we're simplifying the health insurance experience so you can feel more empowered in your health.
Hutchinson Regional Healthcare System. Our family caring for yours.
At Osborne County Memorial Hospital, our services range from clinic visits to inpatient and skilled care, but our specialty is you.
Your family is our family. The staff at Smith County Memorial Hospital wants to set the standard of excellence for healthcare in north central Kansas.
Closer Regional Hospital, experts, neighbors, friends.
Dr. Michael Hagle received his medical degree from the University of Nebraska College of Medicine in Omaha. He completed his residency at Akron City Hospital in Ohio, cardiology training from Washington University Medical Center in St. Louis, Missouri, and interventional cardiology training at the Cardiovascular Institute of the South, Houma, Louisiana. Dr. Hagle has been on staff at Hutchinson Clinic and Hutchinson Regional Medical Center since 2002. He serves as the medical director for the Cardiovascular Catheterization Lab and Cardiac Rehab and has a distinguished reputation across the United States for his work with peripheral vascular disease and limb salvage. Dr. Robert Fleming received his medical degree from the Kansas University School of Medicine in Kansas City. He completed his residency in general surgery at the University of Cincinnati in Cincinnati, Ohio, and a cardiothoracic fellowship from St. Louis University Medical Center in St. Louis, Missouri. Dr. Fleming is board certified by the American Board of Thoracic Surgery and the American Board of Surgery. He is affiliated with Wesley Medical Center in Wichita and is active at Hutchinson Regional Medical Center, Kansas Medical Center in Andover, and Via Christi Regional Medical Center in Wichita. Our phone lines are open at 800-337-4788 toll free if you have any questions regarding cardiology on today's show. Doctors on Call brings you information which may be useful to you when you see your own physician. Thank you both so much for joining us again on our show.
Glad to be here.
Let's talk about something that way we can get it out of the way. How has COVID changed your practice?
You want to take it?
I would say from a surgical standpoint, we often have to, not often, but we have been canceling cases in the operating room because there just aren't any ICU beds to put those patients in. So I think of all the effects it's had on us, wearing masks all the time, etc., the biggest economic thing is to have to change our schedule.
And how are you overcoming these obstacles?
Well, the way that you approach it in the cath lab and the way you approach it in surgery are different. Because the catheterization is a less invasive procedure, we have a little bit more opportunity to wiggle and figure out solutions. And that's probably not going to be feasible with a larger surgical case. In the cath lab, we have become a little quicker to discharge people. Some patients who might stay in the cath lab or stay in the hospital overnight are now going home the same day. So we've just had to figure out ways to do more with less, basically.
Okay, let's talk about what's new and innovative in the world of cardiology.
Okay. I think you should tell them about the Impella because you really started the program.
Okay, well, I'll start out and then we can talk both about surgical and interventional cardiology applications. But, you know, in the cardiac cath lab, we started out doing balloon angioplasty and things like that several decades ago. And we've become progressively more aggressive at what we will treat. In the early days, you would just treat narrowings that were pretty close to your catheter and fairly straightforward. That's changed over time, but as you start doing more and more, you wish you had some kind of safety net while you're working, and the Impella is that safety net. The Impella is a catheter that goes through the groin up to the heart, usually through the groin. Dr. Fleming's approach is different, but usually through the groin up to the heart, and it works on the principle of an Archimedes screw or a well pump. There's basically a screw inside of a tubing that turns, and it'll move up to about 3.5 to 4 liters of blood per minute. And so it basically takes over the normal pumping function of the heart while you take care of the arteries. And on these cases, if everything goes perfect, you're probably going to be just fine no matter what. But if you have any problems and you need time to troubleshoot and figure out how to solve them, you have something there that keeps the patient stable while you take care of that. Now in surgery, the function of the pump is perhaps slightly different, but the ability to hemodynamically support the patient is important in either scenario.
For me, I look at it as either a bridge to transplant. If a person has such a damaged heart that we're never going to get them home off of a device or without a heart transplant, or a bridge to recovery, where somebody maybe has had a big heart attack. We take them to the operating room, operate on them, but their heart needs time to rest. And the surgical Impella is a more high capacity device. It'll pump 5-6 liters of blood. And so we can have these people on it for weeks, even months. And it's been a real good addition to our armamentarium to get these sick people out of the hospital.
Excellent. You mentioned a damaged heart. How does one get how does a damaged heart accumulate, I guess?
Well, I'll let Mike expand on this, but a heart attack is just where the heart muscle dies. They block off a vessel, they have a heart attack, so the blocked off vessel deprives an area of the heart of blood flow, therefore oxygen, and the heart muscle there dies.
Yeah, if you look at slides of hearts from autopsies after a person's had a heart attack, you can just see an abrupt transition from normal muscle to scar or to just pulverized tissue. And so that would be the most common cause of a damaged heart, is a heart attack or multiple heart attacks. But you can also damage it in other ways. For example, if you have a valve that doesn't work properly, if it's leaking all of the time, that volume overload can damage the heart. Or if you have high blood pressure for a long period of time, that can damage the heart. Or people damage their hearts by consuming too much alcohol or by using methamphetamine or things of that sort. So you can get toxic injury to the heart.
Okay. Let's talk about how a person knows if that they have heart disease.
Come see a cardiologist.
Sure.
I mean, that's a question that on the surface seems straightforward, but really figuring it out from talking to somebody isn't always that easy. You do get your initial clues from the story that you hear, and we're interested in symptoms like chest pain, shortness of breath, things of that nature. And so somebody who has those symptoms, particularly in the presence of risk factors for heart disease, you have to at least be suspicious and then look into it more. And there are a variety of tools you can use to do that. For example, various stress tests, sometimes CT scans of the heart, or a heart catheterization. So those are the tools that allow you to make an actual diagnosis.
But symptoms other than this crushing chest pain are very common. Fatigue, indigestion, things that people don't always associate with heart problems. So the term heart or chest pain is somewhat of a misnomer. There's a whole gamut of symptoms.
I had a patient in my last year of training who we took to the cath lab because of pain in the roof of his mouth. And I thought, why are we doing this? I was wondering what my boss was thinking. And he had a narrowed artery, so we were treating it, and every time I blew a balloon up in the artery, he would complain of pain in the roof of his mouth. And I wouldn't tell him. I would just blow the balloon up and see. And when I deflated the balloon, he would say, "Oh, it's going away." So you do get people who are just wired differently or perceive things differently, and so you have to look at more than just the description of pain or pressure or the location. You have to look at the pattern as well.
Interesting. Let's talk about peripheral vascular interventions.
Okay. Peripheral vascular disease or atherosclerosis in the arteries of the legs is very common, and it's the same basic disease as coronary artery disease. In fact, if you have blockage in one set of arteries, you probably have some in all of your other arteries. Whether or not it's clinically significant is hard to say, but if you look hard enough, I think you will find it there. In the legs, peripheral arterial disease will usually cause one of two symptoms. One is pain with walking. Oftentimes that's perceived as being in the calf muscles, although sometimes it's in the buttocks and hip muscles. And that's pain that comes on as people walk, and it resolves with rest. It's kind of like angina for the legs. The other symptom that people will get that's more concerning is either pain at rest or sores on the toes and feet that won't heal. And in those instances, there's a lot more at stake. You have more to worry about in terms of limb loss and so on. And so you have to deal with that second set of people a little bit more aggressively than you would the first group.
Okay, we're going to go to the phone lines. We've got Lori on the line from Bueller. Hi, Lori. Do you have a question tonight for our cardiologist? Hello, Lori. You are live on the air. Lori, you are on Doctors on Call. Do you have a question for Dr. Hagley and Dr. Fleming? We must have lost her. Okay, we'll get back to, maybe Lori, if you, we got cut off, that's fine. You can give us a call back if you still have your question. Let's talk about what DVT treatment is.
Well, DVT is a blood clot in the vein. And that's something that's actually changed a fair bit here recently. Traditionally, the treatment for that has been a blood thinner, like warfarin, or more recently, one of the newer blood thinners like Eliquis or Xarelto or Pradaxa. But you've been usually treating these people for anywhere between 3 and 6 months or for life. And what you're trying to do is avoid that clot extending or having it go to the lung. The downside of that treatment is that some people will develop swelling and discomfort in the leg that won't go away, or it's very difficult to treat. And it's hard to predict up front who's going to develop that set of symptoms and who isn't. So the newer treatment that we're using for some of these is to go in with a needle and a catheter into the vein behind the knee, and to go up with a catheter that basically looks like a really long butterfly neck or butterfly net, and pull that clot out. You can actually retrieve it and open the vein. And that's an effective way of treating these. It doesn't eliminate the need for the blood thinner, but it does reduce the frequency of this post-phlebitic syndrome that I was describing. And we've been fortunate in our lab to have good support from the hospital to get the equipment that we need to do those cases.
Okay, we're going to try Lori again. She's back on the
All right.
line. Hi, Lori. Go ahead with your question for our doctors tonight. We are still not hearing you, Lori. Okay, well, hopefully we can get that figured out, because I'm sure she has a question she's waiting to ask. We are just not hearing her in the studio right now. Let's talk about what minimally invasive heart surgery is.
I think the best way to summarize that is to just say it's doing heart surgery without using the heart-lung machine, without taking the blood from the patient, running it through a machine which oxygenates the blood and giving it back to the patient. So for coronary disease, It would be doing bypasses without putting the patient on pump and doing it with the heart beating. Now you can also have minimally invasive valve surgery where you do have to go on the heart-lung machine, but instead of making a median sternotomy incision, you would make a little lateral thoracotomy incision.
Can you explain what statin medication is?
No,
Oh, I get
you
that.
can.
Yeah, statins are cholesterol-lowering medications. And the idea of a statin is to lower cholesterol levels, but also to lower risk. Now, they're prescribed oftentimes by primary care doctors and then oftentimes by cardiologists. Usually the primary care physicians have a different objective from the cardiologists. For primary care physicians, they are typically doing what would be called primary prevention. They're trying to lower cholesterol and avoid people having first events. And so there's a whole set of kind of protocols for how you use these medications in a primary prevention scenario. For cardiologists, we don't usually see those patients until they've already had an event. And so we're trying to do what's called secondary prevention. We take care of the heart attack or the angina or whatever it is that the person has, and they're feeling better, but we'd like to help them avoid heart attacks, strokes, trips back to the cath lab, death, things of that sort. And so when you deal with a higher risk group of patients, you get a little bit more payoff for your treatment. And there are several good and large studies that show if you take people who have had a cardiovascular event and put them on a statin, that compared to people who are not on a statin, we reduce the risk of strokes, heart attacks, and death. So really anybody who's had a heart attack or treatment for peripheral vascular disease or angina or bypass surgery should be on a statin unless they just can't tolerate one.
Excellent. We were talking about minimally invasive heart surgery. What other types of heart surgeries are there?
Well, your standard heart surgeries are coronary artery bypass grafting, where we take either an artery from the chest wall or a vein from the leg, and we go around the blockages that he can't put a stent through, for example. And then there's valvular heart surgery, where we either repair a valve, mostly the mitral valve, or replace a valve, either the aortic or the mitral valve. Rarely do we mess around with the tricuspid or the pulmonary valves. So coronary surgery and valvular surgery are the two main categories. You could go off and say what goes on in the pediatric world is a whole nother ball game, but we're not doing any of that here.
Sure. Okay, we're going to try this for the third time. Third time's a charm, right? Lori, let's try you again. Are you there?
I'm here. Okay, for now.
Yes. Go ahead with your question for our cardiologist tonight. Are you there, Lori?
Yes, I'm here.
Go ahead with your
Great.
question.
I have been told that the top of my heart isn't talking to the bottom part of my heart. And my blood pressure and pulse are crazy. They're either high or they're low, and I never know when anything happens. I've fallen, and recently I've had a couple of seizures. Both of them in bed. One of them when an aide was with me, and the other one in the middle of the night. And I perspired, which I don't usually ever do.
Can we ask a question?
Yeah.
So who told you that the top part of your heart and the bottom part aren't pumping together or aren't working together?
Are you there, Lori?
Well, I'll do my best
We
here.
lost her. Okay.
So I think what's being described here is that, the heart is a mechanical pump, but it also has an electrical component, which you actually stole my thunder early in the interview because I remember you saying that. So there's an electrical component to that. And there's just one small area in the heart where the electricity is transmitted from the top to the bottom. And if that area quits working properly, then you end up with the top part beating at 80 or 100 beats per minute, and the bottom part just kind of tags along at about 30 or 35 beats per minute. So that can be permanent or it can come and go. Now it's not going to go away completely, but it may be transient. And that can cause some of the symptoms that she was describing, feeling weak, having seizures or loss of consciousness, sweating, all of those kinds of things can occur with that. I wish we could have talked a little bit. The usual treatment for that is a pacemaker, but you have to establish that that's what's going on. Now, there are two types of pacemakers you can use for that problem. Traditionally, it's just been a pacemaker that goes underneath the skin, and you put one wire in the top of the heart and one in the bottom part of the heart, hook them to the pacemaker, and that's your system. There's a newer device that you can insert through a vein in the groin, and the entire device goes into the right side of the heart. And this is an ingenious device. It's implanted into the ventricle, or the bottom part of the heart, but it senses the mechanical activity of the atrium, so you maintain that coordination just based on the detection of the movement of the atrium, and that's been a great option for a lot of patients.
Okay, we do have just a little bit of time left, but we've got another caller waiting to ask a question. This is Yvonne from Great Bend. Hi, Yvonne. Go ahead with your question.
Yes, a few years ago, a doctor put me on a treadmill, and when I got off, he thought I was having a heart attack. And so they sent me to get a heart cath done. And when we had that done, or I had that done, he said, well, you have no problems with your heart. What you have is vasculitis. And I said, well, what do I do about that? And he said, just don't get stressed. Control your stress, because that's what causes it. And he described it as a kind of like a snake restricting itself when you get stressed. Can you explain a little? Is there anything advice you can give me on that at all?
Well, I can only speculate. And what I would say is, first of all, it's pretty common to have the impression that there's a problem on a stress test, and when you look further with a heart catheterization, you find that everything is in fact okay. So I mean, that happens. The stress tests are overly sensitive. The catheterization ends up ultimately telling the story. Now, I'm not sure what the doctor was describing with respect to the vasculitis, so I can only speculate about that, but it sounds like what he may have been describing is spasm in the arteries, and that's pretty common, where if you have emotional stress, you can get contraction of the smooth muscle in the wall of the artery and cause the artery to narrow down, but it's not a fixed atherosclerotic plaque, it's just functional muscle contraction, and you can treat that basically with medicines that help muscles relax, usually calcium blockers or drugs of that sort for the heart.
All right, we're going to try to sneak in one more call here. We've got Sarah on the line from Russell. Hi, Sarah. Go ahead with your question.
Yes, I've been hearing a lot of people developing myocarditis after receiving the COVID-19 vaccine, and I think this sounds pretty alarming. So I was just kind of wondering your thoughts on this, or if you have any experience with this happening.
Well, I've heard about it, and if I recall correctly, it's been primarily the Moderna vaccine that's been associated with that, and it's been primarily in middle-aged men. But I'm not a COVID expert, so don't hold me to that. The myocarditis by itself isn't a problem. It's short-lived and should resolve, so it's not a permanent problem. And I think the decision about vaccination is like everything else. You have to weigh the risks and the benefits, and the risk of developing myocarditis is really fairly low, and the benefit of avoiding at least severe disease associated with COVID is worth something. So nothing's perfect. I think you just have to balance those and talk to your physician about the pros and cons.
And long before COVID, we would see myocarditis. I mean,
Yep.
it isn't as if myocarditis didn't exist.
Right. So, yeah, there's no guarantee you're not going to get myocarditis. You can get it from lots and lots of things.
Okay.
So, but I mean, it's a concern that's out there, and it's publicized concern, that's probably not the thing that would make or break my decision about vaccination.
Myocarditis has gotten all the attention, but the most common subtle, if I can use the word complication of the COVID vaccine, is actually neuropathy.
Okay, very interesting. Well, we covered a lot tonight. Thank you both so much for joining us. We appreciate your time and traveling all this way to be with us tonight. Our thanks goes out to Dr. Michael Hagle and Dr. Robert Fleming for being our guests. On our next Doctors on Call, we'll be discussing dental health. You can email questions for our next program at doctors@shptv.org. Thank you for joining us. For Doctors on Call, I'm Jenna Miller.
Presentation of Doctors on Call on Smoky Hills PBS is made possible in part by an underwriting grant from At Blue Cross Blue Shield of Kansas. We're committed to being a healthcare partner you can turn to. That's why we're simplifying the health insurance experience so you can feel more empowered in your health.
Hutchinson Regional Healthcare System. Our family caring for yours.
At Osborne County Memorial Hospital, our services range from clinic visits to inpatient and skilled care, but our specialty is you.
Your family is our family. The staff at Smith County Memorial Hospital wants to set the standard of excellence for healthcare in north central Kansas.
Russell Regional Hospital, experts, neighbors, friends.